Calling all podcasters, musicians, vloggers, and reporters, and everyone else who wants crystal clear recording that's super portable. The Shure Motive family of microphones makes studio quality audio that's as simple as plug and play. Many of the world's top podcasters rely on Shure, and with a Motive line of iOS and USB microphones, portability is now your friend. Imagine being able to get great audio quickly and easily from your phone, tablet, or computer. Simply visit shure.com/motive to start getting great audio for your content now. That's SHURE.com/MOTIV.
Welcome, everyone, to Creating a Family. Talk about infertility and adoption. Today is a topic that I am really happy that we're covering. We do it almost once a year. We usually get a great response and a great deal of interest from our audience. Preserving your fertility with a cancer diagnosis. Here's a sample of what you're going to hear.
As women get older and that egg reserve diminishes, even a less aggressive type of chemotherapy will render them either subfertile, or in other words, having trouble getting pregnant, or having a reduced window in which to be able to get pregnant, or completely infertile and menopausal. So it's not a cut and dry. You're going to get this treatment, you will become infertile. You get this treatment, you will not. It's sort of it's a degree, and the older the person is, the more likely she is to become infertile after treatment.
This show is brought to you by Creating a Family. I am Dawn Davenport, and I'm the director of Creating a Family, and we are the National Infertility and Adoption Education and Support Nonprofit. And you can find us online at creatingafamily.org. This show is underwritten by our corporate sponsor, Ferring Pharmaceutical. For many women who have been undergoing fertility treatment or are still struggling to conceive, daily scenarios and interactions can take a toll on their emotional health. Ferring has a newly released app called Ferticom, and it is both for Apples and Androids, and it was developed by reproductive psychologist Dr. Alice Domar, also known by, she's a great friend of this show, and we call her Allie Domar, and Dr. Elizabeth Grill. It was designed specifically to help women address the many challenging emotional life situations that almost invariably arise when struggling to conceive. They use cognitive behavioral as well as relaxation techniques, and they offer users more than 500 different coping options for over 50 specific situations that have the potential to cause distress during your family building journey. It's particularly relevant. There's information on holidays. We're approaching that time the next month, certainly the next week and the next month, and there will be lots of opportunities to utilize Ferticom this week as well as in the next month. So I strongly suggest you download it right now. You can get information on it by going to their website, ferticomapp.com, ferticomapp.com. So ferticomapp.com. And I think let me spell that again, Ferticom, ferticalmapp.com. Not sure if I got that spelled right the first time. Download it and let us know if you have used it. I think you'll really enjoy it. Today we're going to be talking about preserving your fertility when diagnosed with cancer. Our guests today are Melissa Thompson. She is an MBA who was diagnosed with stage 3 breast cancer in September 2015, and she is the author and namesake of Melissa's Law for Fertility Preservation. She is also a patient advisor at Memorial Sloan Kettering. We will also be talking with Dr. Glenn Schattman. He is an associate professor of clinical obstetrics and gynecology and clinical reproductive medicine at the Ronald O. Perelman and Claudia Cohen Center for Reproductive Medicine at Weill Cornell Medical College. Welcome, Melissa and Dr. Schattman, to Creating a Family. We're so happy to have you here. Melissa, I want to jump in and start with you. Can you tell us your story and how you came to be the force behind a fertility preservation law?
Sure. Thank you so much for having me, first of all. 2 years ago, I was 32 years old, and I had my first and only child, a daughter, and 5 weeks after she was born, I was diagnosed with stage 3 breast cancer with no family history or genetic disposition. Wow. It really came as a shock. And I quickly, I was one of the lucky ones insofar as I was referred to a fertility clinic. Very few patients relatively actually are educated about the reproductive consequences of cancer treatment. So I was referred to a fertility clinic, and I still am in a state of shock from learning I had cancer. And I'm sitting with a newborn in my arms, and I was asked the question, do you want more children? How many? Eggs or embryos? You have to start treatment today. And I had a double mastectomy scheduled for 3 weeks after that point. So in that time period, I went through fertility preservation. And when I started, the day I started, the office had a billing office, and they called my insurance company. And Connecticut is one of 15 states that has an IVF mandate. So I was told that that this procedure was covered. So I went through with it. And then the day before my egg retrieval procedure, and 3 days before double mastectomy, my insurance carrier called, and they had reversed their authorization because they learned I had cancer, not infertility. And so I was then given a bill for over $12,000 that I couldn't afford, and I had no choice. And I felt that was very, very wrong. I didn't have a chance to really
put it mildly.
I didn't have a chance to really even think about the gravity of it because I went straight into being very sick. And by the time I was able to think straight, the appeals windows had all closed. And cancer patients are often too weak to fight. And so I kind of took this fight on after it would benefit me, but I don't want this to be a problem for anyone else. So I contacted my local legislator, and from there we can get more detailed into it, but I went down the advocacy path to pass a law to make Connecticut the first state to not exclude cancer patients from fertility treatment, because right now in the states that have IVF mandates, all of them have carve-outs, so cancer patients don't qualify because they're not healthy.
And that seems totally backwards in so many ways, because cancer is covered by most, all, I would hope, all health insurance policies, so the treatment of cancer. So it seems so backwards to me that the ramifications of treatment, preventing some of the harms from treatment, wouldn't automatically be covered. But you're saying that Connecticut right now is the only state that has a carve-out?
No, no, every state has a carve-out. Connecticut's the first state to cover it, to remove that carve-out, and then
the opposite of carve-out, right?
Right. So then after we passed Connecticut, our neighbors on one side of Rhode Island passed a law as well to cover cancer patients, and both laws are written very differently. In Connecticut, I worked very closely with the Office of Insurance and the governor's office very early on, and the insurance companies, to make sure we had all stakeholder buy-in. And we actually redefined infertility. The original definition in Connecticut statute was a healthy individual who cannot produce or maintain conception within 12 consecutive months. Yeah. So I started by asking the question, what means healthy? If I have arthritis, am I healthy? If I have cancer, am I healthy? Isn't infertility a disease? Doesn't that not make sense of being healthy? And so there was some agreement there. And then in terms of, I just had a baby, so I would be excluded by the fact that the 12-month period. So we added a comma and said, or by medical necessity. So we just added a few words and a comma and struck one word, and it changed the whole way you can interpret the existing mandate.
Fascinating. We're going to come back and talk more about insurance coverage and other ways to afford fertility preservation treatment before or during a treatment for cancer. But first I wanted to swing back and talk a little about what type of cancer treatments render a patient infertile. And let's start with talking about women. Dr. Schattman, I would assume that not all cancer treatment would affect a woman's fertility. What type of treatments are particularly at risk for causing infertility in women?
Sure. Well, there's a lot of diseases that are treated, not even cancers, that can cause infertility. Any disease that affects the eggs, remember, a woman is born with all the eggs she ever has in her lifetime, and she goes through those eggs over time. Now, if you receive a treatment, and the worst ones really are radiation therapy, many chemotherapies for different diseases, surgery of the ovaries to remove an ovary for a disease that's benign like endometriosis, anything that damages those eggs in the ovaries will actually lead to reduced fertility. And what's really interesting is, people have a finite number of eggs that they're born with, and if you start out really young and you receive a very aggressive type of chemotherapy like a bone marrow transplant or something that's a lot of chemotherapy, you might still be able to get pregnant afterwards. You might still have some egg reserve left. But as women get older and that egg reserve diminishes, even a less aggressive type of chemotherapy will render them either subfertile, or in other words, having trouble getting pregnant, or having a reduced window in which to be able to get pregnant, or completely infertile and menopausal. So it's not a cut and dry. You're going to get this treatment, you will become infertile. You get this treatment, you will not. It's sort of it's a degree, and the older the person is, the more likely she is to become infertile after treatment.
And is it also true that many of the treatments, radiation and chemotherapy, will hasten the decline in her fertility, even if it renders the woman not infertile at the time? Does it speed up the time that menopause will approach, or a diminished ovarian reserve will happen?
Yeah, so just to define ovarian reserve for the listeners, ovarian reserve is just the quantitative number of eggs left in the ovary. So anything that ages the ovary, so as women go through their lifetime, they lose eggs over time, anything that hastens or speeds up that process is going to age the ovary. So, for example, if you have a 32-year-old who's getting chemotherapy for a breast cancer, and she loses half of the eggs in her ovary from the treatment, she still has some eggs left, but clearly her ovaries are acting as if she's much older because they've lost half of the eggs that were left. So a 32-year-old would have the same pregnancy rate as a 38-year-old. She might not be infertile, but now she's 32 years old. Her ovaries think she's 38 years old, and by the time she's 40 in 1 or 2 years, she will no longer be able to get pregnant. So it is a hastening or a reduced window of time in which you will be able to get pregnant, and certainly menopause happens much earlier in people that have gotten chemotherapy, radiation, or anything that damages the ovaries.
Can I add to that? As a patient, I actually didn't know that until the past. I learned this in the past few months. In my mind, chemo equaled sudden death of fertility, and I don't think if it was explained to me, I was not in the right mind frame that I could absorb it. And along the way, my oncology, they treat cancer first. And hopefully there's support services where there are fertility navigators if you're lucky. But I think driving that message home in the beginning, come back after treatment. I never thought of that until recently. And that's one thing I wish I was more tuned into.
What do you mean, Melissa, when you say come back after, you mean that what you wish that you had done was after all the dust had settled, your treatment was over, that you had gone back to a fertility specialist to determine your status, your fertility, the impact on your fertility? Did I understand you? Yes,
and actually, to be perfectly candid, I went recently, and I'm still in the process of checking that, whether I still have fertility left. I only thought to do that, within the last 2 months. But for the past 2 years when I was in treatment, I didn't think it was a possibility. So it wasn't something I looked to for additional hope. But the reality is there is a potential that I have viable fertility left, and I can potentially go through an egg freezing cycle in January, and it might be covered.
Yeah. Oh, interesting. Okay. And before we get off on the different types of treatment, we are certainly hearing a lot now in the news about the various types of immunotherapy. What do we know about the impact of immunotherapies on fertility, Dr. Schattman?
We don't really know very much. Certainly there's some evidence that it does reduce fertility somewhat, and you cannot achieve a pregnancy while you're on treatment, and many of those treatments are long-term treatments. So unfortunately, there's a lot of agents we don't know much about, and the problem with the agents, we don't know specifics about single agents. because most chemotherapies are given as regimens of multiple different agents. So the exact effect of each agent on the egg reserve is really not very well elucidated.
Right. So it's an unknown, and again, so something to be thought, to be considered if you're approaching utilizing that, especially if you've not already undergone chemo or radiation. All right. I wanted to talk some about, Melissa, you described it so well. You've got a diagnosis of cancer. The reality is you are reeling at that point. And then all of a sudden you've got all these other decisions that, if you're lucky, meaning that if somebody tells you that you have these decisions, even mentions fertility preservation. But if they do, you then have, as a woman, different options for fertility preservation. There's to run down a list: embryo banking, egg freezing, even ovarian tissue preservation is an option, although I believe it's still considered experimental. Can you walk us through some of what you've since learned or were told at the time are the advantages and disadvantages of each of those that I just mentioned, and then we'll talk about some other options in a minute.
Can I actually defer first to Dr. Schattman on that? And because I'd love to hear Dr. Schattman, your perspective on how you'd present these options to patients, and then I can tell you how I interpreted them as a patient.
Okay. That's a great idea.
Sure.
Okay, Dr. Schattman, we'll start with you, and then we'll get the patient's perspective afterwards. Go ahead.
I think that's great. I think so. What I first try and do is really an informational session to everybody. I mean, I think most people have either not paid attention in their high school biology classes, or when they were learning about egg reserve and how reproduction works. So I sort of just go through the process of how many eggs there are and what happens with chemotherapy, and then present really all the options that are available. And clearly, I think the tried and true method for most women that have gone through puberty already, so they already have gotten their menstrual periods, and before they're certainly in their early to mid-40s, egg freezing is probably the most effective option for them. And the chance of having a baby for each egg frozen is really dependent on the age of the person. So, for example, if somebody is 32 years old or 33 years old, for each egg they have in the freezer, their chance of having a baby is around 8 to 10%. By the time you're 40 years old, the chance of having a baby for each egg you have frozen is only 2%, and you have fewer eggs. So people that have time to freeze eggs, I present freezing eggs as the best option. If they're in a stable relationship, sometimes embryos make sense also, and you can fertilize the eggs and freeze the fertilized eggs. Second really would be ovarian tissue freezing, which is some women do not have time before they have to start chemotherapy or treatments, and you cannot freeze eggs after chemotherapy has already started or radiation has been given to the ovaries. So ovarian tissue is a procedure where you take out one of the ovaries or a piece of the ovary through a very small incision on the belly through a minimally invasive surgery. You take an ovary or a piece of an ovary out and you freeze the ovary. Remember, all the eggs are in the ovary, so you can then at some point in the future transplant the tissue back into the person once they finish their chemotherapy and they are interested in having a child, and the tissue starts to function again and produces eggs and ovulates, and some people can get pregnant. In fact, there are over 70 babies born worldwide from that procedure, or they will need in vitro fertilization to achieve the pregnancy through the ovarian tissue. So that is successful. It's still considered experimental, whereas egg freezing is no longer considered experimental. And the third option is in people getting radiation therapy to the pelvis, we can move the ovaries out of the pelvic radiation field to preserve the eggs in the ovary. So you sort of have to go through what the effects of the treatments are, what the chance of becoming infertile is afterwards, and then present those three options. And you also have to present the option of not doing anything. Some people would, don't preserve their fertility, and they have options afterwards. Egg donation, they might have a sister that will donate eggs to them, or a relative or a friend, and they can conceive a pregnancy using those donated eggs. In people that have no uterus or have radiation to the uterus where it cannot carry a pregnancy, they can have somebody else carry a pregnancy for them. So we have to go through all the options of what the treatment options are and the option of not undergoing treatment and what the future fertility potential would be of not having treatment. So you sort of have to go through all those things. And remember, these patients are just diagnosed with cancer. They have that diagnosis going in. They don't really they don't really hear everything you say, and it's important they bring a family member, a friend, or somebody else along with them to sort of have a second set of ears.
Yeah, very much so. All right, Melissa, now from a patient standpoint, now this was 2 years ago that you were, so things may have, particularly in the egg freezing area, things have changed in the last 2 years. But what were you told, and what did you hear, and how did you process it?
So first of all, thank you, Dr. Schattman. I think you summarized it very well, and there's so much unsaid in those words that that brings back a lot of memories from this moment, because I got diagnosed with cancer and I was emotionally devastated. I couldn't absorb information. I couldn't make another decision. When I was asked how many children I wanted with a newborn in my arms, I said 6, because it seemed to me like such a ridiculous question, even though it wasn't. It was a real question. I didn't have an answer. But I will say, so 2 years ago, and Dr. Schattman, correct me if I'm wrong, the science hasn't changed significantly enough where there was a large disparate parity between embryo and egg efficacy. Is that correct?
Yeah, so 2 years ago, certainly we were still doing vitrification.
Yeah.
The discrepancy happens as you get older. So if you're 35 and under, eggs and embryos do almost identical. There's really no difference. But over 35, embryos do a little better than eggs.
So that's what I was told. I was told that the science was virtually equal between eggs and embryos. The problem that I had was, as a cancer patient, I don't think that I was treated as the patient, as an individual. I think I was looked at as a couple, as a patient with my significant other. We were not married. And so embryos were presented to us as a first-line recommendation. And that's what I ended up with. And the sad part of it is that I went through the Fertility Preservation and passed a law, and my relationship did not work out because cancer is, 50% of relationships end at baseline, and cancer is really, really hard on caregivers, and it's hard on relationships. And so I lost my fertility preservation for reasons that aren't attributed to science. And so I think, if I were to go back in time, I would try to take a breath, first of all, and try to focus. And I would think, what is the goal? If the goal is reliable fertility preservation, I hope that I could have had better perspective, and I wish my physician had a little bit better perspective on what that means beyond the science, the psychosocial elements of me as a cancer patient and as an individual, and those life circumstances that may put risk on fertility preservation outside the office.
And I'm so glad you bring that up, because it is the autonomy over the use of or your future potential for having a child in the future is, I think, paramount. So while embryos might do a little better, just being able to have eggs in the freezer for you, I think the psychological benefit of that, and not having to be concerned about what to do with those eggs or embryos or eggs at that point if you decide not to use them in the future, I think is one less stress you have to worry about.
And also, I thought recently about what would happen if my significant other at the time, what if he was the one diagnosed with cancer and I was the caregiver? If we went to a fertility clinic, would they ever say to me, the other, okay, Melissa, we're going to stimulate your ovaries and we're going to fertilize them and freeze them? No, they just freeze sperm. It's not. Mm-hmm. It's almost laughable that you'd suggest that. In a situation where you have limited time, you have 2 weeks to have this procedure done, and then you have to have treatment. I don't think we'd ever do that. But if you flip the coin around, as a woman, I was, I say put into that situation. I was party to it, but again, it's the emotional and mental state is very, very difficult at the time. So we, as cancer patients, have to rely heavily on the recommendations given to us, because we don't have the luxury of time or freedom of a clear mind to make decisions or to Google options or to make extra phone calls. So I think the hands that we end up in are, we really rely on our physicians a lot to help guide us.
Yeah, and this is awkward.
I was
going to interject. This is an awkward conversation to have, because you're sitting there in either a marriage or a partnership, and if embryos are presented as the first option, the problem is if the woman even had the wherewithal to say, well, I think I'd rather freeze my eggs, it might imply that she's not sure that this is the partner that she wants to utilize, to have embryos made with. So it's a particularly awkward, it seems like it would put a lot of pressure on the doctor to be the one who is not putting a finger on the scale and presenting options in a way that allows her to choose egg freezing.
So I really appreciate that comment, because I was that person. I was presented with this option, and I knew in my heart that I didn't want to be locked into a situation where I had no options should the relationship not work out. However, it is awkward, and I couldn't fight any more fights. Mm-hmm. And so, when we went home, we could think about it, and he said to me, when I broached the topic of, maybe I should just freeze eggs, and I think many men are more understanding and compassionate, but my significant other said, you don't think I'm going to be the father of your future children? And that, I knew that I didn't have the wherewithal to deal with that at the time. And so I, kind of just gave in and accepted that and said, I will deal with this later. And now is when I'm dealing with this. But what I wish happened, which I wish I was called in by myself to the office, because I was the patient. And I think in an IVF setting, couples are called in together naturally. But in the oncofertility setting, one person really is the patient. And if I had been called in alone, I would have expressed my desires and my values and what I wanted, and not put the physician on the spot to gauge, how is this relationship, because that's not their responsibility. But I would have given the information needed in a setting where I felt safe.
Yeah. Yeah, and I think that's from the there is a need to educate medical professionals on exactly the point that you're making now. That's such a good point. I did want to, Dr. Schattman, come back and ask you about moving the ovaries, ovarian transposition, because I'm curious about that. It's fascinating. So the idea is that depending on the type of cancer, if a woman is going to be getting radiation to the abdominal area, I guess one option, would be to actually shield the ovaries. How effective is that, shielding the ovaries?
Well, you can shield the ovaries depending on the radiation field. So if the radiation is going to be where you need it to be and the ovaries are in that general area, then you cannot shield the ovaries because the radiation has to be in that area. And in that situation, we move the ovaries out of the way. The problem that is that we can move the ovaries high in the pelvis, out of the field of radiation. There's still some radiation that gets to the ovaries, but the uterus is going to be radiated. And the issue with radiating the uterus is it then has decreased function and limited capacity to carry a pregnancy in the future. So some of those women will need, and actually many of them will need, a gestational carrier to carry a pregnancy for them. They can have their biologic child by their eggs have been preserved, but the uterus tends to be damaged and they cannot carry the pregnancy. And that can and has been done.
When you move the ovaries, are they connected to the blood supply, or are you literally cutting out the ovary and then reattaching it to a separate blood supply elsewhere in the abdominal cavity?
So moving the ovaries out of the radiation field, since the radiation field is limited to the pelvis where the ovaries normally reside, is just keeping their same blood supply and moving the ovaries out of the field, so the blood vessel supplying the ovaries still remains. But the ovarian tissue freezing that I was talking about before is when somebody's going to be getting chemotherapy that goes through the bloodstream and gets to the ovary. Then the ovary has to be removed from the body physically and detached from that blood supply and frozen in the laboratory until after chemotherapy is finished. And then the ovary can be transplanted back into the person, and it starts to resume function again.
Gotcha. Yes, thank you for making a distinction. I was actually talking about the transposition. I was imagining how the blood vessels and the blood supply is. So you're limited how far you can move it because you've got to be able to. You want to connect. You want to keep it connected. Hence why the ovaries may still get exposed to some radiation, depending on how far away it can be moved. You know, it's absolutely fascinating that can be done. But you're right. In this case, whether or not the woman would be able to carry her own child, outside of using a gestational carrier, might be carried.
May I add to the notion of gestational carrier for a moment? My oncologist, when I went after fertility preservation, and I went to get the laundry list of things that would happen to me during chemo. It was you will likely have sores in your mouth. Your bones will hurt. You will lose your hair. If you want to have another child, you should use a surrogate. You will be nauseous. That line of you should use a surrogate was thrown into a laundry list of things that were going to happen right then. And I will never forget that she said that. To her, I think that it means a lot less than it does to me. But it brought to my attention, two things. One is how much the weight of her words, carried with me. If I wanted to get pregnant and I chose not to use a surrogate, I would feel bad. I would feel like I was doing something wrong. And I don't know that that my oncologist is that attuned to what's going on in the field of reproductive medicine, and so the choices that she's giving me in the direction are those accurate, and are those really options? Because at Sloan Kettering they have a great fertility and plus cancer program and navigation, and they recommend that women have $100,000 to $150,000 in the bank if they want to go down the route of using a surrogate. So for her to say that to me, is that really an option for me? And actually in New York State, it's not legal to pay a surrogate in New York State. So these other elements, the psychosocial elements and just other elements of care care that is beyond treatment comes into play for a patient and not necessarily the physician at the time.
Yeah, very good point.
Which is also, I think, as you mentioned, the navigation, which is really the pre-chemotherapy navigating fertility, and there are 3 full-time individuals at Sloan Kettering, and hopefully other hospitals will go in the same direction to provide those services to patients. But they really provide information about options in a non-oncologic viewpoint. I mean, the oncologists really are concerned about treating your cancer, curing you. And the fertility navigators really have, I think they sort of intervene between the two, and it just shows you that you should stick with what you're knowledgeable about. If you have, if the oncologists want to talk about fertility preservation, they refer to us, and they refer the patients to us to have that discussion. Because the field is changing. Every 6 months to a year, there are new treatment options and new treatment paradigms, and how rapidly we can do these procedures. And it doesn't take a month; it takes literally 10 to 12 days, where you can start at any point in the cycle. So that fertility navigator, that referral to the specialist who can talk to the patient, have that discussion about fertility preservation, is absolutely critical.
Yeah, absolutely. You were listening to Creating a Family. Today we're talking about preserving your fertility when faced with a cancer diagnosis. This show is brought to you by, of course, Creating a Family, but the reason we are able to bring you this show is through the support of our partners who believe in our mission of providing unbiased, medically accurate information to the patient community. One of our wonderful sponsors is Manhattan Cryobank. They are dedicated to dedicated to helping clients have healthy babies by analyzing a client's DNA in combination with the DNA of prospective sperm donors to provide the client with a personalized catalog of safer donor matches. In addition to sperm donation, Manhattan Cryobank also offers a full range of andrology and fertility preservation services. Dr. Schattman, you alluded to a question that I wanted to raise, and that is the timing of fertility preservation as well as cancer treatment. As Melissa has said, she had a double mastectomy scheduled in 3 weeks. Other people are facing even more rapid potential treatment for their cancer. And at the same time, you're trying to figure out how to, number one, assess your options. But assuming you do that quickly, you still have to, if embryo or egg banking or even ovarian tissue preservation are something that wants to be considered, can you just start immediately? What if you just had your period? What if, or in Melissa's case, perhaps 5 weeks post-birth, she wasn't even ovulating again? How quickly can you do an ovarian stimulation cycle?
That's a great question, and something that I've been even trying to teach many of the reproductive endocrinologists, that the egg reserve is always there. The youngest girl we have stimulated to preserve her eggs has been 14 years of age, and you can even stimulate eggs to grow in girls that have not yet reached puberty because the eggs are there, and all they need is the extra coaxing, the injections of medications to get the eggs to grow. So at any point, as long as the eggs are present in the ovaries, you can stimulate the eggs to grow. And we see referrals for all types of cancers, and it just takes us, no matter where they are in their cycle. They could have just gotten a period. They could be on birth control pills. They could be just about to get a period another week and going to ovulate. So at any point during the menstrual cycle, we can start the injections and stimulate the eggs to grow. The process takes only 10 to 12 days. Usually at the most, it's a 2-week protocol of stimulation, and as soon as the eggs are retrieved in that 2-week block of time at around 10 or 12 days, you can start chemotherapy the next day or any treatments the next day because the eggs are already out of the body. They will no longer be exposed to chemotherapy. Surgery, if someone's having a double mastectomy, we sometimes will freeze their eggs, and they'll go through stimulation before they have their surgery. And then after their surgery, they can do a second round of stimulation. Literally 5 or 7 days after they retrieve the eggs once, they can start stimulation again. So we have women with breast cancer that have gone through 2 or 3 rounds of egg freezing before they have to start their chemotherapy after their surgery. So the process can be done at any point in time of the cycle, and it's quick, and that's 2 weeks. And if they can wait 2 weeks to start treatments, which will not affect treatment, and we always ask the oncologist that if a 2-week delay is going to worsen the prognosis or somehow have a negative impact on their treatment, we will not do it, and then ovarian tissue freezing is the only option. Mm-hmm. Most oncologists, if the disease is not really progressive and treatment doesn't have to start right away, they don't have a problem with 10 days or 12 days of stimulation to retrieve their eggs and then start chemotherapy afterwards.
Dr. Schattman, what about the potential for spreading the cancer, increasing the cancer risk from the ovarian stimulation?
So in women that have estrogen-sensitive cancers or diseases like endometriosis, let's say it's a breast cancer which has an estrogen receptor on the breast cancer, so it might respond to estrogen. We have specialized protocols designed to keep the estrogen levels very low, in fact, about the same level they would have during their normal menstrual cycle, and stimulate multiple eggs to grow. So we have many ways of stimulating eggs to grow safely without raising hormone levels that would potentially increase the growth of the cancer cells. And in the study we did here a number of years ago, we looked at women that froze their eggs or those that decided they were not going to freeze their eggs and go right to treatment, and there was no difference in the outcomes between those two groups. So we feel with the protocols we have, keeping estrogen levels low, it is as safe as not doing treatment and just going right into chemotherapy or other treatments for their cancer.
But if you keep the estrogen or the stimulation drugs low, will you not then usually end up with fewer eggs to freeze, or embryos, depending on which route the woman takes.
No, we're doing a very a physiologic and a normal stimulation protocol. It's just an additional drug which blocks the production of estrogen. So, in fact, we did a study which was really interesting. We compared breast cancer patients using this special protocol to just women coming in to freeze their eggs because they were 34, 35 and just wanted to freeze their eggs electively. And, in fact, the breast cancer patients got more eggs, and they got more mature eggs frozen. So it didn't reduce the number of eggs they had to freeze.
Wow, and that's fascinating. And I wouldn't have thought of it. We did get a question from Simone. She said, I had cervical cancer when I was 26 and had a hysterectomy. This was 4 years ago. I've heard that there are other options now that might have been able to spare my uterus. I guess that Dr. Schattman, you'd probably be the best one to ask that question too. This is specific to cervical cancer. Is it possible to preserve the uterus for a woman who has been diagnosed?
Yes, it is, and it depends on the stage of the cervical cancer because of the way the cancer spreads. If it is a very early stage and a small disease, you can do what's called a trachelectomy, which is really just removing the cervix and leaving the uterus behind, which you have to put a stitch around the bottom part of the uterus to maintain a pregnancy so that the uterus doesn't dilate or it doesn't go into premature labor. And that has been done, and there have been successful pregnancies in women that have had what's called a trachelectomy and preserving their uterus. Clearly, in that situation, you want to make sure you avoid the risk of twins because the uterus is somewhat compromised, and even a singleton pregnancy is considered a high-risk pregnancy in that individual.
Mm-hmm. Yes, but that is something with IVF that we have a high rate of success with, depending on how many embryos that you transfer. So that's something that is a controllable risk. Well, we've been talking about women, but we'd be remiss. Cancer is an equal opportunity villain here. And so let's shift to talking about fertility preservations and options for men. Melissa, I know that as a patient advocate, or I don't know, let me ask, do you work with men as well as women?
So patient advocate, I think, can have many interpretations. It could be an N of one. I could help one patient navigate the system, or it could be in a larger scale. And I consider myself a patient advocate more on a policy level and a structural basis. So I haven't worked with individual males, but I will. From all I can say is it's less invasive and it's less expensive, but that's not a very advanced response. Maybe I'll defer to Dr. Schattman on that.
Yeah. All right. With Dr. Schattman, can you talk to us about when a man has been diagnosed? What are his options? And I think that Melissa is correct. It's certainly less invasive, but let's just talk about what his options are.
Sure. Men are able to freeze sperm. In fact, what's really interesting is when you look at who gets referred for fertility preservation, everyone thinks, sperm freezing is so easy, everyone should do it. In fact, only about 60% of eligible men are even referred for sperm banking. Again, wow. It's truly amazing that it's such an easy thing to do. But they're told it doesn't work very well. Many men have low sperm counts from systemic disease. If they have leukemias or lymphomas, they tend to have low sperm counts just because of the disease process itself. But we only need as many sperm as we have eggs to fertilize with in vitro fertilization. And so even if there's a couple of thousand sperm in the ejaculate, you can still freeze those sperm and have successful pregnancies. So men are usually referred to a sperm bank. Where they can freeze before chemotherapy again. They can't have started chemotherapy, but before chemotherapy, they can freeze a sperm sample. They can produce the ejaculate at the facility. They can produce it at home and bring it in a sterile container. So those options are available. And there are sperm banks scattered throughout New York and in many states have a facility that is able to freeze sperm long-term for men. The success rates are excellent. Again, the sperm different from eggs because the sperm is a very small cell. An egg is a very large cell with a high water content. Think of putting a bottle of soda pop in the freezer. and the water expands and contracts. The same thing happens to the egg. But sperm is a very small cell with very little water content, so they freeze and thaw very well. So the success rates with sperm freezing is excellent. Most of the men, if they freeze enough sperm beforehand, can use that sperm for insemination, just putting the sperm inside the uterus when the woman is ovulating or their partner is ovulating. Oftentimes the sperm quality is not good enough and they need in vitro fertilization to achieve a pregnancy, but they still are able to achieve a pregnancy if they're able to preserve sperm before they start chemotherapy.
And I don't want to spend too much time on this, but I also do want to talk about special issues that need to be considered when children are diagnosed with cancer. This one becomes even more complex because at this point the parent is making a decision. Oftentimes it's an awkward conversation for some parents to have with their child, especially a younger child. But how far have we progressed, Dr. Schattman, as far as you mentioned that it is possible even for a girl who has not reached puberty to be able, did you say you were able to stimulate egg production, or at that point were you just preserving ovarian tissue?
No, we were able to stimulate egg production by giving the same injections that somebody would take for in vitro fertilization. Now remember, this requires daily injections and blood tests and sonograms to monitor growth of the follicles, and most 12 or 13-year-old girls are really not emotionally prepared or mature enough to do that, and so the only option for them would be to take out one of the ovaries and freeze the ovarian tissue. But it is possible to do, and the same thing is true for young boys. If they have not reached puberty, they don't have sperm production, and so the only option for those individuals would be to freeze a biopsy of testicular tissue for potential future use.
The main thing is that we want parents to be thinking about this. We want oncologists to be talking with parents so that at least a decision can be made as opposed to not even knowing that they have an option. Melissa, do you want to add anything on this one?
I think that it touches on a point that's applicable for all. When one gets a cancer diagnosis, it feels all-encompassing. That's all you can think about. But the reality is that survival rates are increasing. And as survival rates increase, is the number of years you have in your life beyond cancer is greater. And so cancer doesn't have to define your life. It can be one chapter. But at the time, it feels like it's everything. So I think, again, I shoulder the physicians with a lot, but, the physicians, the caregivers, the parents, they have the ability to give patients perspective on that when a patient can't, achieve that perspective for him or herself.
Yeah, I had a conversation with a family just yesterday, actually, a young girl, and it's really about providing options for them. It's giving them information and providing options, and keeping options open.
Yeah, and the thing, and I second what Melissa said. Sometimes that perspective has got to come from the medical community because the family, the patient, and the family are really not in the best position to be making. They're just overwhelmed. They're making decisions on, they're Googling survival, they're Googling treatment, they're Googling, they're connecting with other patients. They're making so many decisions, and decision fatigue is a real thing that just overwhelms people.
I also just want to add, we think about the first thing I remind is saving our own lives. So it's hard to make the jump from saving our own lives to creating more lives.
Yeah, that's such a good point. Yeah, all you're at that point thinking about is survival, which is how it should be. That should be the focus. But somebody else can help you think long term when you can't, and that is the medical community. Well, there's no conversation in anything to do with infertility that doesn't involve money on some level. And we started off talking about, Melissa, your experience, because paying for fertility preservation is a real issue. Not only are people facing additional cost, loss of work, incidental expenses, caretaking and things like that associated with the treatment of cancer, but now they're having to face the cost associated with preserving their options to have children in the future, or have biological children in the future. So, just circling back to Melissa, what you had said at the beginning, and I want to make sure I'm understanding you. Most states, even those that mandate coverage for infertility, exclude infertility preservation needed for people who are diagnosed with cancer. Did I understand you correctly?
That's correct. Until my law passed in Connecticut and then Rhode Island, not one state that had a mandate had included that mandate did not include cancer patients. So IVF coverage treatment was covered, but if you were a cancer patient, fertility preservation was not covered. And that's in part because, sometimes the argument was, we don't cover things that don't happen yet. So, we give you breast reconstruction because you've had a mastectomy. You're not currently infertile, but we know that there's a certain percent chance that I will be. So that's where some of the pushback came in. And this is in Connecticut where it was really something amazing happened, where everything came together because we understood each other. And where I brought the argument on that one was, there is one example where government does pay for it, and it's blood donation to yourself before surgery. You don't need it yet, but it's covered. Mm-hmm. And so kind of debunks that argument, and it looked more towards preventative for infertility for the first time, and just opening people's minds as to, we can avoid failed IVF cycles after cancer if we just preserve the fertility before cancer treatment.
Do you happen to know, there are, even though a state may not mandate coverage, certain employers, particularly larger employers, will often cover, not often, I shouldn't say that, sometimes cover fertility. Do you know if most of the policies that are being provided by employers also exclude fertility preservation for patients, for cancer patients?
I think they're more lenient, and many of them do and don't exclude it automatically. And that being said, in terms of high self-insured employers, that's a place where people can advocate to their employer directly and appeal to them directly to make that change in a policy. So it's a kind of
absolutely.
Yeah,
that's something that we work with Resolve on, the National Infertility Association. We work with them on getting the word out that you can make a difference in getting infertility covered through your company policy. I interrupted you, Dr. Schattman. Go ahead.
No, I was saying we do a lot of work with the Alliance for Fertility Preservation and Resolve. We have gone to Albany, and I'm sure, and Melissa can tell you that she's had these discussions and conversations with many legislators. The cost of this treatment is pennies for covered lives or per covered life. To be able to offer these options before chemotherapy starts would be pennies. The cost of treating these patients afterwards is very expensive and thousands of dollars. So it's really just trying to look ahead. Offering these services, having this covered, would really not add any expense to people's policies, and it just makes good sense. It makes common sense to do this and prevent these types of tragedies afterwards.
It makes common sense. That's exactly right. Go ahead, Melissa.
When I was diagnosed and I was given these options, I didn't have to make that choice of whether I wanted to incur that debt because I was accidentally put into a situation by error where they said I was approved, they reversed it, so I never made that choice. If I had sat down at that table and they said, here are your options, you can incur $12,000 to $15,000 of debt with money that you don't have. You can potentially forego having children for the rest of your life, or you can think about what treatments are less toxic and compromise your own outcomes. And that is a Cornelian dilemma. There is no good answer to that.
There's no good answer.
I hope that, kinetic is the first step but I hope that in the future there's a day when my daughter is, my age, that people will not know this to be a problem, and people will all have realized that it's not fair. It's not fair, and it's not even fiscally sound. That, we can cover all pieces of this argument of why it does not make sense to foreclose these options from young, the AYA, the adolescent young adult population. It affects. We're a very narrow population, but the effect it has on us is incalculable.
Absolutely. And I go back to, I think, what Dr. Schattman said. It just makes common sense and fiscal sense. I mean, ultimately, the insurance companies would be, saving, and to say nothing of the PR. If you're going to help anyone, this would be the population you would be actively trying to help. Let me take a moment to tell you about another one of our partners whose generosity allows us to bring you this show. We have Fairfax Cryobank. They have been supporters of Creating a Family for many years, and we truly appreciate their partnership. They are a leader in sperm donation for over 25 years, and they are dedicated to supplying updated, verified, and accurate medical and personal information on their donors. Only 1 in 200 applicants make it through their screening process to become a donor. Melissa, we've talked about insurance, and that's obviously the preferable option for paying for fertility preservation. But other than are there other options other than raiding your savings account or beg borrowing and money from to pay for the treatment? Are there other options available for cancer patients? Are there organizations that provide monies to help cover or provide treatment, fertility preservation treatment without cost?
Sure. And I want to add to one thing you said. You said deplete your bank account. I actually had to put my embryos on my American Express card because I didn't have the wherewithal to, beg, borrow, and steal or figure anything out. So I put them on a credit card. And I will say the collections and billing departments at fertility centers are not as forgiving as cancer centers. And that impacted me as well. I had to make a quick decision. And cancer center, I was an inpatient. I couldn't even open an envelope to pay a bill, and I was getting calls with threats to go to collections. But beyond that, there are Ferring Pharmaceuticals and Walgreens have a program called the Heartbeat Program, and so some of the drugs needed for this are free to cancer patients, which is really a beautiful gesture. And beyond that, most drug programs have copay assistance programs, and you need to ask your physician's office staff for help because you can't do this alone. And actually, everyone wants to help when you get diagnosed with cancer. How can I help? This is an area, payment and financial avenues, where you can maybe ask people to help you look for resources because there's the SAM Fund. They give grants. There are Livestrong has partnerships with different fertility clinics have discounted rate for cancer patients, but it's hard to come by. It's hard to get an entire preservation cycle covered. So you might be able to farm that out to your friends and family who want to help you.
That's a great idea, particularly if somebody is a good researcher and that's up their avenue. Dr. Schattman, do clinics have discount programs? Do some clinics, you can't speak for the universe of all infertility clinics, I realize, but do some clinics have discount programs or other than getting a reduced cost on meds, which is no small thing, let's be honest. So the Heartbeat program is certainly one. Other thoughts for how patients can pay for this?
So we have a program where there's a significantly discounted rate for individuals. Medications are free, but for any of the medical procedures, there's a significantly discounted rate for patients, and payment plan options are available for the remainder. And I tell patients this all the time, that the finances should not be a reason why you should not undergo this. If you want to pay $10 a month or $20 a month and make a payment plan, I have absolutely no problem with doing that. So I think many programs and many centers will offer discounted rates. But in addition, we will certainly allow patients to make payment plans like credit card bills and putting things on American Express at 18% interest is not where I want people to be financially strapped to be able to at least preserve their fertility. So.
Yeah. So and at the end of this show, I'm going to ask each of you to suggest resources. I also have a list of resources. So if you're listening, stay tuned. We'll give you some resources which will jumpstart your research on your options, but as well as your options for payment. You know, one of the questions, we got a couple of questions, but generally the questions were dealing with the safety of pregnancy after surviving cancer. And so I wanted to talk about that both from the patient's standpoint as well as from the baby's standpoint or the fetus. So let's start with what is currently known as far as how safe is it for someone who has undergone treatment for cancer to get pregnant and carry a pregnancy to term. And undoubtedly the answer is going to be somewhat dependent on the type of cancer, the stage of cancer, and things such as that. Dr. Schattman, since it's a medical question, let me start with you.
So in terms of the safety, it depends on, again, as you said, the type of cancer and the stage of cancer. But if most people are free of disease, or what we call NED, no evidence of disease, 2 years post-treatment by chemotherapy, there is no evidence that cancer or recurrence rates for cancer are at any increased rate over women that did not get pregnant. And let's take, for example, the most concerning one. People always talk about breast cancer. It is an estrogen receptor or receptive type of cancer. If you take somebody who is 2 years post-treatment with no evidence of disease, and you look at, and there's a number of studies out there that have looked at pregnancies and outcomes after pregnancy, and there's absolutely no difference in outcomes in terms of recurrence rates for women in terms of their breast cancer. It is safe for the babies. The only situation where there might be some risk is, again, as I talked about, the radiation treatment to the uterus for diseases in the pelvis, that the uterus has diminished function or the chances of pregnancy and complications of pregnancy are much higher. But as far as we know,
birth would be one of the concerns, I would assume.
Absolutely.
Miscarriage
Something
or
called
premature birth,
right, lower blood supply, so intrauterine growth retardation, smaller babies, increased risk of miscarriage, those types of things from radiation to the uterus.
Gotcha. So, and that is predominantly associated with radiation, which exposure in the uterus. Well, thank you both so much for being with us today to talk about this really important topic. I do want to shift now to talking about resources. Let me mention a couple, and then I'm going to ask Melissa, first you, and then Dr. Schattman. First, the Alliance for Fertility Preservation is a wonderful resource, and they actually have a thing on there called the Fertility Scout, and it helps you find fertility preservation specialists if your oncologist is not able to recommend someone. The Fertility Consortium is another good resource that provides all sorts of information. Melissa, can you suggest some as well?
Sure. So I can suggest some that are grants for patients. Fertile Hope gives grants. Sam Fund gives grants. Fertility Within Reach. Livestrong. Reprotech for storage, discounted storage cost. I pay $1,000 a year still for embryos I can't use, but there's cheaper storage options. And one thing I want to say about price, though, is, I see these targeted ads on Facebook and Google showing me $4,000, $5,000, all you can freeze eggs. And there are these places popping up for egg freezing. And that looks like an attractive option when you look at a price tag. And I think Dr. Schattman probably could add to that. I want patients to make sure they're cautious about balancing the science with a cost offer.
Yeah, sometimes low cost is less effective, and increased costs over time. So 3 cycles of IVF with a lower chance of a good outcome afterwards is more expensive than a single effective cycle of IVF. So I think you have to be very concerned about or wary of, buyer beware type of mentality.
Yeah.
All right. So in addition, Dr. Schattman, to the Alliance for Fertility Preservation, the Fertility Consortium, Fertile Hope, Fertile Action, Alliance for Fertility Preservation. I just mentioned that one. Any others? And Livestrong was one that you mentioned. But go ahead. Any others, Dr. Schattman?
Yeah, the Resolve is involved also, a heartbeat program through Ferring, and there's other drug companies have similar types of programs where they offer free medications. And those are really changing, and the fertility specialists would be the one to be able to tell you what programs might benefit you at that point when you are needing those assistances.
I have one to add, an esoteric one. Move to Connecticut or Rhode Island. But
we're working on other states.
Need to do with a cancer diagnosis, talk about adding stress to your life.
but what I can say is you can advocate in your state to have this change,
and with your employer.
Right.
So absolutely, it matters. Your voice does matter. And Melissa, if nothing else, you are proof of that. You were the moving force for changing a law that affects the entire state of Connecticut. I am in awe, and I'm giving you a standing ovation right now. We need more women. We need more people, I should say, in general, who will stand up and make a change. As you say, the change didn't help you, but it sure as heck helped a lot of other people who have come behind you. So on behalf of the women of Connecticut, let me say thank you.
And let me say back to patients how meaningful your voices are, and you may not know it, but laws are made that affect us in windowless rooms by people without the subject matter expertise, and they're looking to do the right thing. They need the stories and the authenticity that comes with being an advocate and showing up for a public hearing. Yes,
they absolutely do. And for people to vote on with this in mind and talk to your representatives and do all the things that we recommend that people do for any advocacy effort. Thank you, Melissa Thompson and Dr. Glenn Schattman. Let me remind folks that the information given here is general and is not intended to take the place of the advice you will be getting from your medical doctor and your fertility specialist. Do us a favor and pop over to iTunes and give us a ranking. We are by far the number one ranked show in this topic area, and we would love to stay there. And the way we would stay there is through your star rankings or comments, either one. So do us a favor and pop over and give us one, and we're very appreciative. Thank you so much for joining us today, and I will see you next week.
Your hands were made for greatness. Mighty hands for painting, paneling, and clicking the submit order button on HomeDepot.com to get that duvet. And these Egyptian cotton towels delivered right to your door. Do more with decor at the Home Depot. Save up to 30% on select bedding and bath. Now at HomeDepot.com. More saving, more kinds of doing. Valid on select items online only. Free delivery on select items $45 or more. Enter promo code BEDBATH15 at purchase for an extra 15% off. Visit HomeDepot.com for more information. Everything you're hearing is from the Home Depot. From the baseboards and nails to these throw pillows, even those super soft sheets. Because now at the Home Depot, you can get everything for your bedroom, from wooden nightstands to modern benches. Save up to 25% on select bedroom furniture, plus free and flexible delivery and easy in-store returns. Shop decor now at HomeDepot.com. More saving, more kinds of doing. Valid on select items online only. Free delivery on select items $45 or more. Visit HomeDepot.com for more information.